the most important, actually, thank you, Dr. Soo, for actually agree to join, to spend his time to share with us his experience on how to do the ventilation strategy in the congenital heart disease. So just a brief introduction for Dr. Soo. He's actually graduated from UPM, and then and subsequently did his pediatricians taking the MRCP-CH, and subsequently went on to become a pediatric cardiologist in IJN. Then after that, he further sub-specialized in the pediatric cardiac intensive care in Royal Children's Hospital in Australia. So Dr. Soo is not a stranger to us. So he is most of the time is our main liaison officer when we want to refer case to the IJN. So I also actually very grateful to him, as without his teaching and his passion to teach, I wouldn't have survived the 5 months on call in IJN. So without further ado, I would like to invite Dr. Soo to present his talk.
Yeah, okay, thank you, Siwa. Siwa and myself goes quite long ago. We are both from UPM, so we know each other from our university days. And then she joined me in Klang, and we worked together in Klang and came to IJN for quite a long period of time, longer than most of the other SRs in their training in IJN. So yeah, of course, when she asked, I cannot say no. Yeah. So anyway, today I'm supposed to share with you all about ventilation strategies in the congenital heart disease group. So in this group, before we move on, basically this talk has got 2 parts. The first part on cardiopulmonary interaction, about how the heart and the lung interact with each other with and without positive pressure ventilation. And then we go on to talk about some of the cardiac lesion, how we approach the ventilation for this group of patients based on their pathology of the heart. So first, to start off, you see a lot of pictures here, but the one that I want you to focus on right now is this one. The heart is housed inside the rib cage, so with a diaphragm closing at the bottom. So this is somewhat like a sealed compartment. The heart right in the middle with all the blood vessels coming from the top as well as bottom. So the heart is suspended in the middle. And then you have the lung filling up the space at both sides. So if the lungs are very much hyperextended, it will squeeze the heart. And if the heart is very dilated, it will compress the lungs. So we have this confined space right in the middle. And within the heart itself, they are further confined by the pericardial sac. You see this picture here, the pericardial sac has 2 layers, and the right and left ventricle, right atrium, left ventricle, they are all confined within this pericardial sac. And it being in the pericardial sac, any dilatation of any of these chambers will have to shift the interventricular septum and affect the volume state of the other side. Like in this picture here, you see a dilated RV pushing against the LV. So if your LV is pushed, you will have difficulty filling it up. And if you cannot fill up the ventricle well, your Frank-Starling laws tells you that you can't have a good cardiac output from it. So with this basic understanding, you see anything that happens within this confined space will affect each other. Then, of course, this is a simplified picture, having known that venous return will come through the right ventricle, the right side of the heart, and then the right side of the heart will pump to the lungs, and then the blood coming back from the lungs, oxygenated, coming to the left side of the heart, and then pump back to the circulation. So the blood movement is everybody's knowledge. What happens in between? During spontaneous respiration, the first thing that occurs is the diaphragm contraction. In a resting state, you have all the things we mentioned just now. The pleural cavity and the pleural space itself is a little bit negative because of your your all the fluid inside, the small amount of fluid inside between your pleura as well as your rib cage. Your rib cage being a very stiff structure, holding everything together is slightly negative. So when your diaphragm starts to contract, you take a breath in. So the whole pressure system inside, the pleural pressure will actually become a little bit more negative. So when that happens, what happens to the blood? You will get, we have to focus on the right side first, and then we talk about the left side on the spontaneous inspiration. So when your diaphragm contracts, your pleural pressures become more negative. There's an increase in the gradient because everything inside this cavity has become more negative, and the pressure outside remains the same. So blood will rush into the heart from the SVC as well as the IVC going inside the heart. This is easy to understand. As this thing contracts and becomes more negative, everything inside here is also being sort of sucked in. So your vascular beds in the lungs will also open up. So blood will rush in from the all different parts of the systemic circulation into the right side of the heart and pump to the lungs to get oxygenation. So that is all good. When inspiration happens, it's easy for blood to come inside the lungs. But what happens to the left side? When they get oxygenated, it will come back to the left side of the heart and then fill up the left ventricle, and then the blood will be ejected out. But because the cavity here is a bit negative, so the blood will try to remain in this cavity, and you will have difficulty getting the blood out, because that is how it goes when spontaneous inspiration occurs. So basically, spontaneous respiration is good for the right side of the heart, whereby blood comes in easily, but it's not so good for the left side of the heart because of this negative intrathoracic pressure. Blood will be kept inside this cavity. So afterload actually increases, and it's difficult for the blood to pump out. But all this is not a problem if your cardiac function is normal or you are only mildly impaired. So there is no problem with blood ejecting out from the heart under normal inspiration. So all is good. So this is the normal way we calculate the transmural pressure, because this is the pressure that we explain whether the afterload is increased or decreased in relation to the left ventricle. But this is all easier to mention when you have positive pressure. So that is on spontaneous breathing. What happens if you add on, you intubate the patient, you put a ventilator on, and you actually push pressure into the lungs? So this is now becoming positive. So every pressure inside this system, you have put in a tube and actually push pressure into this intrathoracic space. So all the pressures at the site will become positive because you're actually pushing pressure. So as we mentioned, if the pressure inside here is positive, of course, the gradient between the vessels outside and the gradient inside becomes narrow. So blood will have difficulty actually coming back into the right side because of this positive pressure. You can easily imagine that a pressure going higher on this side, blood coming in, difficult. So of course, blood going to eject into the lungs, also more difficult. So you have your reduce in your right side preload. But what about the left side? So after the blood gets oxygenated and comes back to the left side of the heart, and this area now is positive. So when your heart is ejecting, your left side of the heart is ejecting blood out, this space being positive, it'll be easy for blood to actually get ejected out into the surrounding systemic circulation. So positive pressure, not so good for the right side, but very good for the left side, because it actually helps the blood get ejected out from the heart. So as you see all these kind of numbers being shown, the left side afterload, again, we talk in terms of the transmural pressure. You see the pressure within the left ventricle minus the pleural pressure, you get your transmural pressure. And if you put positive pressure, this number becomes positive, and as you minus the pressure, actually becomes lower. As you look at the other picture, the transmural pressure for the left ventricle, under normal spontaneous respiration, when you 80 minus with negative pressures, you actually get a higher pressure. But like I said, this is not a problem for a normal heart. But if you have a heart that is compromised in low function, then it becomes a problem, because the heart may not be able to overcome this small increase in the pressure. And of course, there's also the baroreceptor reflex. All these great vessels, they are housed within the thoracic cage. Putting pressure onto them or having negative pressure will also affect the receptors within this great vessel. So if you put a lot of pressure, the vessels at the systemic end will actually vasodilate, and then you have a reduction in your LV afterload. So to sum up, during normal respiration, it is easy for blood to come into the right side and go to the lungs, but it is more difficult for blood to get out from the left side of the heart. During positive pressure, it is difficult for blood to get into the heart, but easy for the blood to get out from the left ventricle into the systemic circulation. And of course, the nice terms to use to describe all these things are all these preload, afterload, transmural pressures, and such. But the gist of it, to understand simply, is just that it's just because all organs are confined within this thoracic cage. A few more factors that we need to understand as we talk about ventilation is this. These vessels are the ones that are inside the alveoli. You will have all these kind of alveoli, bronchial arteries and veins. So the best way to ventilate a lung is to ventilate at the functional residual capacity. So that is when the lungs are well open, but not too expanded. The vessels are all in normal configuration, so there's no problem there. Let's say if you do not give enough pressure to the lungs, and then the lung actually get atelectatic, they will shift the curve towards this direction. So when your lungs are collapsed, your blood vessels are also collapsed along with it. So when you are at this particular end of the ventilation, when you are at very, very small tidal volume, such that the alveoli are actually collapsed, your blood vessels are also collapsed and crooked. So then you see this graph says the PVR actually increases in the lungs as your lung get atelectatic. If you push too much pressure into the lungs, you see all these areas getting very, very dilated. The alveoli are very pressurized. They will exert a strong pressure on all these vessels, compressing the vessels in between these alveoli, flattening the vessel. All these things will also increase the pressure within the vessel, thereby increasing the pulmonary vascular resistance. So ventilating at very low tidal volume that causes lung atelectasis increases PVR. If you put too much pressure into the lungs, it also increases the PVR by different mechanism. This mechanism caused by collapse of the alveoli, collapse of the vessel, and this one caused by compression of the vessel by the surrounding distended alveoli. So either way, no good. So the best is to be able to ventilate within this ascending limb, this part of the limb, whereby we have kept the lungs open to a good position and keep ventilating at this position. Hence, you don't have de-recruitment of the lung and don't have hyperinflation of the lungs. But this kind of graph, you all are more familiar than me. You all have seen this graph a lot more and probably talk about opening pressures, closing pressures more than me. But what I want to stress is that too big tidal volume, no good. Too small tidal volume, also no good, because the vessels in the lungs are affected and the pulmonary vascular resistance go up. And what about other factors? When we ventilate the lungs, we also need to know a few things that affects it. One of the thing that is the biggest contributor to whether the lung the pulmonary pressures go higher or lower is alveolar PaO2. So oxygen to the lungs. Oxygen causes vasodilatation in the vessels in the lungs, hence reducing pulmonary vascular resistance. So like this particular graph, as you see the PaO2 increases, your maximum pressure response decreases. So the pressure in the lung actually reduces. So the vasoconstrictive ability of the pulmonary vessels become lower. So oxygen is a vasodilator to the pulmonary vessels. What about pH? You see the PVR increases as the pH become more acidotic. Under normal pH, it is this. As your pH increases, your PVR also increase. But pH is not only a factor of your carbon dioxide, it's also a factor of your metabolic state. Either or, it also affects the pH and it also affects the PVR in the lungs. So we should not have too much acidosis now. So oxygen, pH, carbon dioxide, they are big factors to note. What about this west zone? West zones described some long time ago now. They tell you about ventilation and perfusion matching. Let's say at the apex of the lungs, they note that the alveoli are easily ventilated, but blood flow not well perfused. All these alveoli, they are ventilated but not well perfused because the pressures in the alveoli are actually higher, compressing the vessels a lot. What about as you move down into the lower zones? These are the bases of the lungs. These are the place where oxygen and carbon dioxide are actually greatly exchanged. You see the pressures in the lungs are not as big as top, and the vessels are actually open. So you actually have more contribution of gas exchange in this zone 3 rather than zone 1. So if you have lung atelectasis at the bottom part of this zone 3, you will notice that the PVR for the patient is greatly affected. Like we were talking last week about diaphragm paralysis, and then diaphragm paralysis causing space occupying area around the base of the lung. Those are very important areas because they contribute a lot to gas exchange. If you have a diaphragm that is actually paralyzed and actually occupying space here, then you'll find that a lot of this place cannot be used for gas exchange, compromising the patient's oxygenation as well as ventilation. So these factors we need to note. What about other factors? Things like blood viscosity, they increase the hematocrit. So sometimes patients that have very low hemoglobin, transfusing blood can help increase the hemoglobin, but PVR can also increase. Other factors like catecholamines, arachidonic acid, they also increase PVR. If the patient is very alkalemic, they decrease PVR. This is sometimes what we do when we have patients with pulmonary hypertension. We adjust these kind of things. Hypothermia increases PVR a little, and alpha receptors causes vasoconstriction, beta receptors vasodilatation, muscarinic receptors vasodilatation, and these are the other inotropes that we use in the ICU very often: adrenaline, noradrenaline, and pulmonary vasodilators like nitric oxide, which we use a lot, merinone, levosimendan, sildenafil, vasopressin. These are all friendly for the lungs. When you have a patient with pulmonary hypertension, these inotropes are good for lungs. And then calcium channel blockers and ACE inhibitors and such. Okay, what about the specific cardiac condition? So we will talk a few about this, then easier for y'all to ask later about what y'all do at your site. So the left to right shunt, what are left to right shunt lesions? Left to right shunt lesions are things like ASD, VSD, PDA, AVSD. These are the common left to right shunt. So during the time when you have uncorrected patients, you have a defect at the ventricle. The easiest to use is probably ventricular septal defect. So blood returning from the left side of the heart comes to the left ventricle, but will go through the VSD going back into the lungs again. So what happens here? Cardiac output is actually diminished because part of the cardiac output is lost through this VSD going to the lungs and flood the lungs increasingly again and again, volume loading the left ventricle, causing a cardiomegaly. And as you see, most of the lungs are actually quite wet. Of course, if you have a patient in prolonged situation as such, you'll find that you have fluid in the alveoli, the interstitial space all filled with fluid. The hydrostatic pressures in the lungs are very high. The oxygenation may actually drop because of this reason. You find that a patient in not so overt heart failure may saturate well, but as the patient becomes more in severe heart failure, the saturation may actually drop because you have now a lot of fluid inside in between the lung space and all that. And now the patient actually requires some oxygen. So how do we ventilate this group of patients? So there's a study here by the anesthetist. So they actually went to the OT and did some form of experiment before they put the patient on bypass, before they operate on the patient. And they actually tried using different amount of tidal volume to see whether the shunt flow is actually increased or not. So there's a person at the there's somebody doing echo in the theater, looking at 10 mils tidal volume, 8 mils tidal volume, 6 mils tidal volume, and then they find that as the tidal volume decreases, the shunt actually decreases. So they find that ventilating a patient with VSD with low tidal volume is actually useful, able to wean down the amount of shunt they have. So the common strategy we use in that we probably advise people is to use low amount of oxygen, because oxygen, as we mentioned earlier, is a vasodilator. So we don't need a lot of oxygen. If the patient's lungs are not badly affected, if the heart failure is still early, then we do not need so much oxygen. You probably need very light 21-25% oxygen. But of course, if the patient is stuck on your positive pressure for 1 month and you are unable to achieve much diuresis using medical means alone, as you continue to ventilate these patients, you see that the oxygen requirement increases. PEEP, as we discussed earlier, reduces the amount of blood flow to the lungs, hence able to keep the lungs a bit drier and helps with reabsorption of the fluid as well. So we usually keep the PEEP at moderate levels. PIP is just enough to achieve our tidal volume. As we mentioned, don't use a very high tidal volume because lower tidal volumes actually reduces the shunt across the VSD. Rate is to compensate and achieve adequate minute ventilation. So for VSD, it's a very common lesion. All of you should know what to do with a patient with VSD. Pulmonary hypertension. Pulmonary hypertension, in this picture, we are sort of showing there are a lot of reasons for pulmonary hypertension. The WHO pulmonary hypertension grouping, 1, 2, 3, 4, 5. So the type 1 where you have actually got the muscles in the lungs actually increasing, causing the blood flow to actually decrease. So that is the common, whichever the type of pulmonary hypertension, finally the pressures in the lungs get increased, either from left side disease, from lung pathology, or having a shunt. In most of our cases, the pressures in the lungs continue to go up. So how do we ventilate this group of patients? Most of the time we mentioned we don't need very high tidal volume. We don't like very high PEEP also. In terms of oxygenation, you can be a bit more generous in your giving of oxygen, the FiO2. For patients that are right after surgery and all that, I usually keep it a little bit higher just to prevent pulmonary hypertensive crisis. And oxygen is a vasodilator, so that's all good. PEEP, we try to keep a low PEEP, just enough to make sure we don't have lung atelectasis. And then, PIP to get adequate tidal volume. Don't use a very high tidal volume, compensate it with a bit of a higher rate just to maintain adequate minute ventilation. PaO2 a bit on the lower side to achieve a bit of alkalosis to reduce your pulmonary pressures. Let's say if the patient develops sudden pulmonary hypertensive crisis, what I usually tell my bedside nurse is to sedate the patient a bit better and then hyperventilate the patient, give a bit more oxygen, increase the respiratory rate. Usually, most of the time, this aborts the crisis event around the bedside. Of course, these are things that we need to be able to educate our nurse so that everybody is on the same page when it comes to managing this patient. The most important thing is to make sure these patients are well sedated, paralyzed, so as to not trigger any crisis. Single ventricle is something fairly complex, and there are many stages to managing a single ventricle patient. Basically, in the cardiology aspect, any heart that is unable to maintain two left and right side circulation is considered single ventricle. Either they have very, very large defect causing a lot of mixing in between, or they have very hypoplastic one side of the heart causing the other side to be dominant, or outflow tracts that are very diminutive, very small, unable to support two circulation, the pulmonary and the systemic. We group them into single ventricle. And in single ventricle, there are basically about 3 stages in the surgery. The first stage is determined by whether the patient has adequate pulmonary blood flow or not. If there is too much pulmonary blood flow, we might end up with a PA band to reduce the amount of blood to the lungs. Or if they don't have enough, maybe BT shunt or PDA stenting to increase the blood flow to the lungs. And we need to know how to balance the circulation for this group of patients. So this table is from a talk that I've given some time back. I usually look at it in terms of a big V here and a big Q here and some other factors. So most of the trouble with all these shunts or stents is that they are either underflowing in the sense that it may be on the verge of blockage, or they are over circulating, they are over shunting. So let's look at the block shunt part. So when you look at block shunt, what are you trying to do with the lungs? You are trying to promote more blood flow to the lungs. So your ventilator strategies will need to be one that does not have too much pressure. You keep a lowish PEEP, and then you improve the tidal volume and the rate, and you can afford to be a bit more generous in your oxygenation to maintain as low as possible lung pressures, your intrathoracic pressures to remain as low as possible. And few of the things that we do is that we also use a lot of vasoconstrictors like NORAD and adrenaline, because as you can imagine, the BT shunt and the PDA stent is a connection between the aorta and the pulmonary artery. So if you use a lot of systemic vasoconstrictors, you will tend to push blood through the shunt or the stent into the lungs. Maintaining a good amount of heparin, fluid boluses, and such. If you are in the situation where you over-circulate, of course, your ventilation strategy will be such that you want to put a lot of pressures in the lungs so that blood cannot get into the lungs that easily. So usually we end up with a very high peak, very low tidal volume, and hypoventilating the child to bring the CO2 up, because CO2 is a vasoconstrictor, like we mentioned earlier in the factors of the pH. If your CO2 goes up, your pH actually comes down, and that is a vasoconstrictor itself. So we do that to reduce the amount of blood flow to the lungs. We use systemic vasodilators as well as some adrenaline sometimes to promote increased cardiac output so that the blood pressures are not too low. We diurese the patients a lot, as well as transfuse some blood, and then if we may need to control the flow a lot more. So what about this Glenn shunt? For those unaware, Glenn shunt also called bidirectional cable pulmonary shunt. This is a shunt whereby we connect the superior vena cava directly to the RPA. You see the picture of this drawing. There is tricuspid atresia as well as pulmonary atresia. There's no flow from this side, so blood actually comes in, crosses the interatrial septum, and then goes out of the heart this way. But the upper part, this is the second stage of single ventricle palliation, where we dissect the SVC, we connect it directly to the lungs. So blood flow from the upper body actually comes into the lungs directly through the SVC. This is the other diagram to show. The upper body has this form of circulation. When the heart contracts, blood is ejected from the heart, going through the main blood vessels, going to the upper body, and comes back through the SVC, goes to the lungs directly, and comes back with oxygenated blood and mixing back in the single ventricle. The lower part of the body actually gets deoxygenated blood and mixes back to the single ventricle and comes back out this way. So how do we ventilate this weird circulation? Actually, there is some progress with the way they ventilate this patient. If you look at it, what do we want from this circulation? We want blood to come into the lungs easily. So of course you would tend to think that, oh, I will need a lowish PEEP. I will need a highish, I will need to blow out my CO2 well so that my lungs have low PVR. And in that way, we hope to be able to promote blood flow into the lungs. This is the initial thought, because you mentioned this is all passive circulation. Blood has to flow in without the right ventricle pumping them into the lungs. So you thought that you would want something low PVR ventilating strategy. You would think that CO2, you want low CO2. But when they started doing this, it didn't turn out very well. So this is the first Parma Hokoste. This is one of the pioneering study which look at how to ventilate a Glenn shunt. So they went on a sort of a dam. They tried to make people understand in the form of the dam physiology, whereby if you do not have flow from the dam, whatever you do at the bottom will not work, because there's no blood flow coming through first. So what they did in this particular study is that they actually added CO2 to the ventilating gas. And then when they actually added CO2 to the ventilating gas, they find that oxygenation improves. That is something that is looking weird. How do they explain that? If you put carbon dioxide into the lungs and cause vasoconstriction in the lungs, how do you actually get more oxygenation to occur? So what happens? CO2, as you know, vasoconstrictor to the lungs, but vasodilator to the systemic circulation. So when they put CO2, it actually goes to the upper body perfusion. It causes vasodilatation in the brain. So when they vasodilate the vessels in the brain, there is more blood going to the upper body, to the brain, and coming back as venous return through the SVC. So with this increased amount of blood flow, it actually flows to the lungs better. And when you actually have more blood going to the lungs, you can have better oxygenation. So with this particular study, for the first time, they have proven that instead of a strategy trying to lower CO2, you allow CO2 to trend upwards, it actually improves the oxygenation for this group of patient. And finally, of course, you need to extubate them early. So the strategy for patients with this kind of gland shunt, in the peripheral hospital, you may not see many of these patients, but sometimes they do come in for URTI or pneumonia. So you need to remember what we discussed here. The FiO2 you can give as needed, but the target of the PaO2 is also not very high, about 50 millimeter mercury. The peak, we usually keep a very low peak, about 3 to 5, but not to get lung collapse from it. PIP just enough to get tidal volume. Tidal volume, we also don't target very high, because we allow the CO2 to be about 45 to 50, 55 sometimes. You see? So yeah, this is what we do for our gland shunt. After we gain stability, we usually try to extubate them early. So in the peripheral setting, if possible, don't ventilate this group of patients. What about Fontan? This is the third stage of single ventricle palliation. I have put up a few pictures here. We no longer do the other types of surgery here. We are now mainly only doing extra cardiac Fontan. So in gland, the earlier stage, we have put in the SVC right to the RPA. To complete the circulation, we will put a conduit from the IVC to the pulmonary arteries as well. So now the whole venous circulation to the lungs is passive and get oxygenated and come back to the left ventricle to be pushed out. So these are early studies also about how they ventilate this group of patients. So they tested this thing out by actually using different PEEP levels. They start with PEEP of 0 and then going up to 3, 6, 9, 12. So they noticed that as they increase the PEEP, the cardiac output actually decreases. And then blood pressure actually falls, especially when the PEEP reaches somewhere around 9. It has become very significantly prohibitive to the blood flow in the lungs. So from this study, they have recommended that you should not use high PEEPs for Fontan circulation. But there are many things in Fontan circulation. It's not as just that. But the mantra for ventilating Fontan patient is to extubate them as early as you can to get them extubated once stable. So FiO2, again, we use a moderate amount as needed to get a PaO2 at least 60 if there is a fenestration. That means a hole between the conduit and the RA. Or if they are non-fenestrated, at least 80 normal PaO2. PEEP, we use very low PEEP, same as earlier in gland shunt, and then PIP adequate for tidal volume, low tidal volume strategy, and low rate allows spontaneous breathing. And again, the CO2 we allow a bit highish. But actually many ways to try this out also. No matter how, the easiest way to get a patient post-Fontan to have good cardiac output is by extubating the patient. What about in right ventricular dysfunction? This picture, I think, shown to y'all at the beginning also, where there are one small picture that shows if you have a right ventricle that actually dilates a lot, your left ventricle gets compromised because they are confined within the same pericardial space. As you can see, even in this picture, the left ventricle is having difficulty filling up. So as as the patient actually starts failing, you have the ventricle that actually increases in the PVR, RV afterload increases, the stroke volume starts decreasing, and as the RV volume gets even worse, it compresses upon the LV and your LV gets poor filling. And if the LV is not filled properly, you don't have proper cardiac output, and patient goes into low cardiac output. How do we ventilate this group of patient? Of course, not easy, because as amount of oxygen we give as needed. The PEEP, we usually keep it a bit low. But as you know, these patients, if you have right ventricular dysfunction, you'll find that the lungs are also full of fluid. So sometimes it is not so easy to keep a PEEP that is low. You have a lot of lung atelectasis as well. So you need to adjust your PEEP as needed in order to make sure the lungs are not collapsed. From the picture of the earlier graph of the PVR, if the lung is atelectatic, the PVR goes up even higher than actually when you push up pressures. So having a lung that is open is the best. So PIP as needed, tidal volume, lowish tidal volume usually, and the rate is high enough to maintain minute ventilation. So you don't want to push too much pressure because you know that the RV cannot pump blood towards the lungs. So you don't want a very high pressured lungs whereby the afterload of the RV is too high for the sick RV to contract against. So in that situation, what about extubating this group of patients? It is desirable to extubate the patient if we can, but you have to take note that, let's say if the RV is really, really sick, and the RV, when they are sick, they are usually very dilated, and when they are very dilated at the time, the LV is compressed. If your patient still has significant RV dysfunction, it is not advisable to extubate them, because if you extubate them, the RV dilates even more at that point of time, causing more compression of the left ventricle. You can sometimes get APO from this situation, because suddenly you lose the support of the LV afterload reduction from the positive pressure ventilation. LV struggles, totally loss of cardiac output, and you create a situation where you have actually acute pulmonary edema. So not desirable to extubate a patient with right ventricular dysfunction when they are still in a deeply dysfunctional state. But the strategy on theoretical level is still to early extubate them once they are stable. Left ventricle is somewhat like the way we were describing earlier, situation like the left ventricle, like the VSD patient, where you have, if you have the pathophysiology is often when you have a failing left ventricle, there's a lot of pulmonary edema, lung compliance poor, yeah, the transmural pressure increases, and then you have a lot of work of breathing, the LV struggles even more, and it becomes a vicious cycle. So when you put in positive pressure to the lungs, you do a few things. To the lungs, you actually, by pushing pressure through to the lungs, you actually push the water out of the lungs. So you can decrease the work of breathing by instituting some form of positive pressure. Of course, the preload also reduces the venous return, and then increases the PVR a bit, more difficult for blood to actually reach the lungs. And when that actually happens, when you have reduced blood flow to the lungs, actually there will be reduced venous return to the left side. The left side, if it is dysfunctional, is again a very dilated left side. So having a reduction in the preload helps reduce the volume loading of the left ventricle. And afterload is also decreased because you actually increase the intrathoracic pressure, reducing the transmural pressure. And yeah, all these things will help reduce the oxygen demand and increase the oxygen delivery. So the strategy is somewhat like how we were dealing with the VSD. Lowish FiO2, moderate PEEP, PIP as needed, low tidal volumes, and rate enough to maintain the minute ventilation. Okay, so that is all in the presentation. We can engage in discussion.
Thank you, Dr. Soo, for the excellent talk. So every time I listen to this, the lecture from you, I definitely will get some more new knowledge from you. Yeah. So is there any questions from the floor?
Yeah, Dr. Soo, thank you for the wonderful talk. Actually, it helped us to clear more doubts as we are seeing the patient day to day, every day on bedside, but still getting confused how to manage with the patient with the higher pulmonary flow and what to do with the patient with the lower pulmonary. I mean to say, what will be the strategies for to increase the PVR, decrease the PVR, and this presentation helped to clear the doubt a bit. I'm sure it's going to help us managing the patient on bedside at PCICU and PQ. But I wanted to know more about the adjusting the inspiratory expiratory ratio, and then something about inspiratory time, how to adjust depending upon the clinical scenario. It would be nice if you could talk a bit about this one, if possible. Yeah.
Which part do you want to talk about? The shunt one or the basically all these things in application is basically looking at what you want to achieve from the right side of the heart or what you want to achieve from the left side of the heart. If you and your eye time is just a measure of how much tidal volume you want to deliver for the patient. If you think you want a tidal volume that is low, you can adjust the eye time to achieve your tidal volume. So at the bedside, let's say if you see you want a tidal volume of 8 mils per kilo, but if you're using a PRVC mode, you find that 8 mils per kilo you need a pressure of 22. But if you do not, if you're trying to treat the right heart, you don't want so high pressures, you can increase the eye time longer to give more tidal volume at the expense of a lower peak pressure. So that is how we play at the bedside. If you want, if you're asking in terms of the eye time, how much eye time, because we are looking at the tidal volume that we want to deliver and whether we are actually focusing on helping the left side or helping the right side.
Okay.
Because it is a bit counterproductive if you have a very short eye time, but a very high peak pressure to achieve the tidal volume you want. Let's say if you want an 8 mils, but you put an eye time of 0.3 seconds. That 0.3 seconds, you need a pressure of 25 in order to deliver the same tidal volume. So that is not very practical. You have a very high pressure, but the eye time is very short. So we balance it by increasing the eye time. You can reduce the peak pressure.
Okay.
Does that answer your question?
Yes.
If not, we can go to the bedside and I can show it to you. Shilpa is one of my fellow in the ICU right now.
Thank you so much, Dr. Soo.
Yeah.
Okay. So actually the strategy that we learned from Dr. Soo lecture also actually can be applied to our patient with ARDS. So basically, I use a lot of strategy learned from IGN to apply in my patient who sometimes who have a severe lung infection. So that kind of things. So actually, recently also I actually has a child like a TGA with intact ventricular septum. Actually, I have a problem with like stabilizing the child. So therefore, actually, I consulted Soo the other day to help me to manage the child. So actually, Dr. Soo, can you just maybe teach us again, like the ventilator strategy for TGA with the intact ventricular septum or with the VSD is actually slightly different, right? Sometimes
depends on what we're trying to achieve. Usually for TGA patient, you don't really need a lot of pressures to ventilate. But of course, many of our patients are kept in the hospital for a long time. They have a very big PDA, and the PDA actually causes heart failure in the patient. Then the strategy to manage that lung will be more akin to a patient with a big shunt. So we apply the pressure in the lungs to reduce the amount of blood flow to the lungs. So let's say if you have a patient whereby the PDA is already very small, the patient is very blue, then I would not give high pressures in the lungs. I will give pressures that are lower to promote blood flow to the lungs. But TGA is not a very good example because no matter what you do to the TGA patient, if the patient does not mix very well, that means if the interatrial septum is restrictive, no matter what ventilator strategy we apply, we still need to perform the balloon atrial septostomy to open up the interatrial septum to promote more oxygenated blood going into the systemic circulation. So I guess how we want to look at it is dependent on what we want to achieve. If you want to promote more blood flow to the lungs, you try to don't use too much pressures in the lungs, lower tidal volume, lower pressures, higher oxygenation to promote more blood flow to the lungs. If you do not want blood to the lungs, then you push pressures a bit higher. You get what I mean?
Yeah, thank you.
Yeah. Basically, I sum up what I want to do with the ventilator with just looking at whether my focus is trying to help the right heart or the left heart, and whether I want to get more blood into the lungs or get less blood to the lungs. So my ventilator strategies goes according to this concept, and knowing that the heart is housed within the lungs, all the pressures that we apply will have interaction with each other. And whether you have a right side that is too big or the left side that is too big compressing the right side, all these things are very important to take note. So if you have this concept in your mind, then you can apply this to any cardiac condition that we want to treat. Because even in a patient like a tetralogy of Fallot at the time when they come to your hospital might be very blue. So if the patient is very blue and you want to apply a strategy whereby you want to reduce the lung pressures so that the RV don't have to contract against a very high pressure lungs. So your ventilator strategy is often one that has lowish peak, just enough to operate at functional residual capacity, and then low pressures, highish oxygen, and lowish tidal volume. So that is how I look at it. And if I have a situation whereby you have a myocarditis and the patient has a very weak ventricle, the contractility is very poor, then you want to make sure you help the left ventricle a bit more. So you want a pressure that is a bit higher on the lungs. You want something that is like maybe a PEEP of 8 to 10, and then oxygen that is just adequate to get adequate PaO2, and then keep the patient ventilated for a little longer so that you can dry up the lungs. You can reduce the amount of blood flow going to the lungs, hence reducing the amount of preload to the left ventricle. And then the left ventricle, which is very weak, very dilated, has a chance to shrink in size and improve in contractility. Once the left ventricle function is much better, then you can consider, okay, I want to extubate this patient, but I want to be safe. So I prepare my non-invasive ventilator, maybe extubate directly to non-invasive ventilator. So for me, yeah, this is how I look at it, whether I'm trying to focus on the right heart or the left heart, and whether I want to promote blood flow to the lungs or reduce the blood flow to the lungs. Yeah. Itu dia. The others the other junior member of the ICU community, do you all have anything to ask? So with this background knowledge, you can use it to apply a different scenario. And if you can think of something you want to ask, you can ask now. Or maybe you have a patient with HOCM, hypertrophic cardiomyopathy. So that is a situation that is also very difficult. The left ventricle is a very hypertrophic heart. So how much of pressures do you want to put in the lungs? If you all understand Hokum, I'm not sure whether I can make you all understand Hokum or not. Hokum is basically the left ventricle that is full of muscle, and there's very little blood flow actually coming into the left side one. So your pressures, you cannot use too high pressures because you actually want blood going to the lungs so that the blood can come back to the left ventricle so that you have some volume of the left ventricle and you are able to eject. So pressures you shouldn't keep too high. And then oxygenation, yes, you can give as much as you need to achieve adequate PaO2 targets. And then once you're ready, you can extubate this group of patients. So if you have anything to ask, can ask. Oh, I actually talked for almost 1 hour already, man. Right. I thought there are only a few slides, but we still end up talking almost 1 hour.
Yeah. But the information you share during these sessions is memang very valuable. Thanks Kok Wai for the time.
Myra got some question, right? Myra.
Hi, Dr. Soo.
Hi,
Thank you
Myra.
for sharing. Hi. I just always confused when you say you increase the time inspiration to increase the minute ventilation for this group of patients by increasing the rate sometime. How will you set the IE ratio for this group of patients? I mean, I always have sometimes confused lah in regards of this, because you are going to compromise the aspiration time also.
Yeah.
How you, can you advise us on that? And then the other thing, when a patient, this is the first question. The second question is in a patient with the post-gland, post-fontan, and up to our ICU for so-called ARDS, then how are we supposed to fine-tuning in regards of choosing the PEP to ensure that lung and the heart is happy? So
very
that's the
difficult.
two. Yes. Because
so just now the first question where you want to mention the I time IE ratio. So like I was trying to explain to Shipa, usually we say normal patient you want 1:2 ratio, 1 inspiration, 2 expiration ratio. But to be able to achieve that 1:2 ratio may not be that easy. So looking at the amount of tidal volume you want, you can, because some of the ventilator you adjust the IE ratio to be able to get the tidal volume. But for me, as long as we do not compromise too much of the expiratory time, I am okay to increase inspiratory time. As long as I achieve my tidal volume. Of course, I try not to go into inverse ratio ventilation whereby I have a longer inspiratory time than expiratory time. It depends on the balance, because sometimes even in your ARDS, you may end up with, if your oxygenation is so poor, you end up with high and long I time and a shorter expiratory time just to be able to gain enough oxygenation. So I wouldn't have a great formula for that. But how I deal with it in IGN is that I usually at most go to 1:1 ratio, and then look at the amount of tidal volume I need, and then adjust the length of the I time to be able to achieve my tidal volume. That's what I usually do. As for a gland who end up with ARDS, then banyak susah lah. Because the gland shunt patients, if you put a lot of pressure in the lungs, you'll find that the head become congested. You can actually literally see the veins in the necks and all that things becomes engorged. If you have a patient with gland shunt that actually has very high ventilating pressures. So this group of patients has very poor prognosis. Let's say if this single ventricle patient actually end up with a severe pneumonia ARDS, they may not make it, no? because they really depend on a very fine balance of not very high pressures in the lungs. Because if you put the pressures very high, you can really see the neck vessels getting engorged in the head, and prognosis becomes poorer by the day, unless you manage to treat the infective cause and then able to put less pressure in the lung. Maybe try things like HFOV or something that does not apply too much pressure to the intrathoracic side. If you ask me honestly, have I treated a Glenn shunt with ARDS or not? Well, probably not. So yeah, I can tell you the theory behind doing it. If I were to have this patient, yes, I will try to make sure the lungs are as open as possible, but without too much pressure. So things like HFOV and all that things might be useful, as you do not use the maximum pressure that you can apply.
Thank you.
Hey. Okay. Hey, this talk I'm supposed to give also during the ventilator course that you all want to have next month. So is this adequate for that course or not? Or you all want me to adjust some of these slides to for that course?
We'll talk about it later.
Okay.
Yeah, I'll
Alright.
ask Anis to live with you, because Anis is the organizer.
Is Anis around or not? I thought if Anis is around, she could give me some feedback as to whether this content of the talk is able to answer the questions that she posed or not.
Anis, I think busy in the work. He got the ill child. The child on.
Is Anis in this talk? No.
No, Anis, I think is busy in the ward. He had a ill child in the
Oh,
unit.
okay.
Yeah. Good.
Any other question? If not, then sekian, terima kasih.
Yeah, thank you, Dr. Soo, again for the excellent talk.
Right. Thanks. Thank you so much, Sue. Thank you for your time and to prepare all this talk and sharing your knowledge. Yeah, as I say, we're looking forward for the next talk. We will give you the topic, and whenever, hopefully, in time to come, you can have a chance to listen to your sharing our knowledge again. Thank you so much. Yeah.
Okay, correct.
And we will have altogether about 73 participants at the peak. Yeah.
Okay. Right.
Okay. Thanks so much. Thanks.
Terima kasih.
Sama-sama.
Thank you, Dr. Soo.
Yeah.
Thank you, Dr. Soo.